senior registrar at the university that I went to. And so that is just a particular, on a personal note, very exciting for me to welcome her to our community, as well as she will be joining and attending other sessions as we reach out to all of our colleagues across the globe. So before we begin with her presentation, just a few housekeeping rules. If everyone can stay on mute during the presentations, it's up to you if you'd like to leave your video on or off. We will have 3 presentations, and thereafter we will have a question and answer session. Throughout, you are more than welcome to post questions in the chat, or during the question and answer session, please feel free to raise your hand, turn on your video and microphone, and ask your questions yourself, so that we create a nice conversational atmosphere after what will surely be 3 fantastic talks. So to begin, as I mentioned, our first speaker is from South Africa, Dr. Annsureeka Ganesh. She's a senior registrar in the Department of Neurology in Johannesburg, and she's currently practicing at Chris Hani Baragwanath Academic Hospital, which is the largest hospital in Africa. She has experience working in a wide range of neurological disorders, but with a special interest in neuroimmunology, and is enthusiastic about highlighting these conditions and about NMOSD in South Africa. So I will now share my screen, and I hope you enjoy.
Good evening, my name is Annsureeka Ganesh, and I'm a registrar in the Department of Neurology at the University of Witwatersrand here in South Africa. And tonight I'm going to be sharing some of our experience with NMOSD with you. I'd like to start by giving you a bit of background into our healthcare system. I work and have been trained in the public health sector of South Africa, which provides healthcare to just over 80% of our population of around 59 million people. We have a referral system which extends from smaller clinics and district level hospitals to tertiary and regional hospitals, where the majority of our specialist care is centered. Currently, we have around 140 registered urology consultants in both public and private healthcare, and this excludes registrars who train in the public sector. These numbers can be quite overwhelming, so I'd like to focus a little bit more to give you some perspective. So a few weeks ago, quite fortuitously, I was consulted to see this patient, Ms. KL. She's a young Black female with no prior medical history from a rural area just outside of Johannesburg. She presented with lower limb weakness and early bladder involvement for about a week, and she had gone to her local clinic closer to where she lived, but she was discharged with an unclear treatment plan. In further inquiry, she actually had a bout of excessive vomiting for about 3 days prior to that, and was given antiemetics by her uncle. After about a week, her family friends realized that she wasn't improving and organized transport to bring her into the city. When we saw her, she had a complete transverse myelopathy with no features of TB or any other autoimmune diseases. And she received an MRI of her brain and spine urgently, which showed this longitudinally extensive lesion. And our differential at this stage included NMOSD, so she was started on IVI steroids whilst awaiting the rest of her investigations, including her lumbar puncture. You'd be forgiven for thinking that this was just a textbook case, but Ms. KL's story demonstrates 2 key points that I'd like to highlight today. The first is the obvious time delay from symptom onset to diagnosis and treatment. We know that reducing time to treatment is crucial in NMOSD, and there are multiple factors that encompass patients' beliefs and awareness, access to healthcare, and appropriate referral and treatment, which unfortunately is not a unique story in South Africa. The second point is that Ms. KL also shares similar demographics with about a fifth of our population, which is incidentally similar to those proposed to be at higher risk for NMOSD. The prevalence of NMOSD in South Africa has previously been reported to be around 5 per 100,000, and this was reiterated in June last year by Puppet L, where they also noted a higher prevalence of NMOSD in females who are middle-aged and of Black or African ancestry. Unfortunately, to date, the exact prevalence of NMOSD in South Africa and many other African countries is largely unknown, mostly due to a paucity of data. One of the earliest published cases of possible NMOSD in South Africa was described in a Black patient by Hefton Woodley in 1973. In 2011, Modi et al. Described 8 Black patients with multiple attacks involving different neuroanatomical sites in a case series from Chris Hani Baragwanath Hospital. These patients presented with LETMs, optic neuritis, and brainstem syndromes. And again, we see a female predominance in a younger age group. Their findings on MRI were heterogeneous, and they overlapped with possible ADAM and MS type lesions. However, the clinical progression of disability and poor response to steroids was more in keeping with NMOSD. More recently, when antibody testing became available, Dr. Ismail Mullah studied 22 patients presenting to our academic hospitals. 15 of these patients had a diagnosis of NMOSD, and of these 15 patients, he noted the same demographic presentations that were previously described. 8 of these patients had anti-aquaporin 4 antibodies that were positive, and 7 of them were negative, but at the time, anti-MOG antibody testing was unavailable. The most common finding was a cervical LETM with central cord involvement, and 7 of these patients had a combined optic neuritis with the cervical myelopathy. At presentation, all but one patient had an EDSS of 8, and 4 of these patients were HIV positive, all of whom were diagnosed and virally suppressed prior to their diagnosis of NMOSD. Notably, none of the patients in the NMOSD group had a diagnostic correlation with TB. South Africa has the largest HIV epidemic in the world, accounting for almost 19% of the global population of people living with HIV. HIV and TB go hand in hand, and it's undoubtedly the most common opportunistic infection in South Africa. Of course, patients can have more than one disease, but the co-occurrence of HIV and NMOSD, and particularly the simultaneous presentation of both, is uncommon. The association between TB and NMOSD, however, dates all the way back to at least 1990, when Silver et al. Described 8 patients with NMOSD clinical features who presented soon after or at the time of their pulmonary TB diagnosis, but showed no CNS involvement of TB. They suggested that the syndrome was due to an immune-mediated reaction secondary to TB. Numerous other studies have described these possible associations as well. In 2011, Zachura et al. Published a retrospective study of 14 adult patients in the Western Cape of South Africa who had a final diagnosis of NMOSD, 11 of whom had a preceding or simultaneous diagnosis of pulmonary TB. Also in 2011, Modi et al. Described 97 patients with non-traumatic myelopathies, approximately half of whom were HIV positive, with most of these patients having a CD4 count of less than 500. Only 2 of these patients with HIV had a final diagnosis of NMOSD, whereas TB accounted for about a quarter of the other myelopathies. Big G et al. Retrospectively reviewed 29 adult patients with NMOSD in KwaZulu-Natal. 12 of these patients were HIV positive, and once again we see a Black female predominance of a similar age group and clinical presentation. Interestingly, the radiological features were in keeping with NMOSD in all of these patients except 3 of them who demonstrated these tumefactive type lesions, which may have been similar to those described by Modi et al. In 2000. The antibody status of these patients, however, is unknown. Infections triggering other autoimmune processes is not unique to TB and HIV. So what happens with other infections? The new kid on the block, COVID-19, seems to have overshadowed TB, and the numbers from last year show a dramatic decline in reported TB figures. However, we know that this is very likely due to a number of reasons, from underreporting, undertesting, access to healthcare, etc. But if we apply the same immunopathogenesis theory from HIV and TB to COVID, are we expecting to see more patients with NMOSD in future? And will their clinical characteristics remain the same? The answer, of course, is that we currently don't know. And the only way that we will know the answer to this and to many other burning questions is through data collection. Nationalized databases for patient data are currently unavailable in South Africa, which makes collecting and accessing data reflective of our population quite challenging. Our department has recently implemented an electronic system on which we capture our discharge summaries. So I'd just like to share a snapshot of some of the data from just the past 2 years in 3 of our academic hospitals. So we've diagnosed 12 patients with NMOSD, excluding Ms. KL. And once again, we see a similar demographic and clinical presentation to that which has been previously described. other than the slightly older age group. 3 of our patients here were HIV positive, all of whom were on ARVs and virally suppressed, with CD4 counts more than 400 at the time of their NMOSD diagnosis. Only 3 of these patients presented in the past year, and of them, only 1 patient presented during the midst of the COVID pandemic when routine testing was being done, and she was COVID negative. So just going back to Ms. KL, she unfortunately did not respond to IVI methylprednisolone, so she went on to receive 7 days of plasma exchange, as is typical for our escalation protocol, but unfortunately she made no recovery in terms of her weakness. Her TB workup was negative, and she was later found to have a positive ANA, which was speckled with high titers, and she was diagnosed with SLE by our rheumatology colleagues. She was later stepped down to a rehabilitation facility, and then after about a month, her aquaporin 4 antibody result was released, and this was negative. Ms. Kao's journey from presentation to treatment highlights key areas that we can learn from. Our experience of NMOSD in South Africa seems to share similarities with those described internationally. However, we're faced with a unique set of socioeconomic and biologic factors that are likely to impact the disease course in our patients. Further research will be needed to explore the entity of NMOSD in South Africa and improve knowledge regarding manifestation of disease in our population. Confounding factors and treatment outcomes are crucial to improve awareness, allow for earlier diagnosis, and ultimately translate to improved patient care. Thank you very much for your attention.
Great. I hope you all enjoyed that presentation, highlighting some of the characteristics of NMO and also the challenges faced treating patients with NMO in a South African context. So now, moving on, I'm very excited to move away from the developing world and to move to a different context, which is a pediatric population studied in Oxford. So it is my great pleasure to introduce you to Dr. Valentina Camera, who is currently working with Professor Pallas in Oxford. She is currently the Clinical and Research Fellow of our National NMO Service there. She is a specialist neurologist from Verona, and in 2020, she was awarded the European Charcot Foundation Fellowship, and that's what brought her through to Oxford to conduct her research. So it's my great pleasure to hand over to her now for the second presentation of this session.
Thank you, Romina. Okay. Can you see it? Okay. Now you have to do this also. Okay, fine. Welcome everybody. This night I will talk about our study. It is a multi-center study about early predictors of disability of pediatric onset aquaporin 4 IgG seropositive neuromyelitis optica spectrum disorders. No, okay. About 5% of aquaporin 4 IgG seropositive NMOSD have a pediatric onset. In this subgroup of patients, female prevalence is between 60 to 80%. As in adult, in this subgroup, there is a higher prevalence in non-white and Asian ethnicity. And as in adult, aquaporin 4 IgG seropositivity predicts disease relapse. In a study conducted in 2008, published in Neurology, were investigated which were the onset phenotypes of pediatric onset aquaporin 4 positive children. And they found that 53% of these children had optic neuritis, 22% transverse myelitis, and only 60% had brainstem symptomatology, of whom 16% had a Repostrema syndrome or brainstem syndrome. Because neuromyelitis optica disability is related to relapse prevention therapies are indicated to decrease the risk and severity of relapses and subsequent disability. currently we have available rituximab, mycophenolate, and azathioprine, but there are also future options which are going to be assessed also in pediatric population as eculizumab, tocilizumab, satralizumab, inebilizumab, or ofatumumab. And there are no published data on these drugs in pediatric aquaporin-4 positive patients. For the clinical trials, disability outcomes are important because we have to assess whether these drugs can influence the disease course and also the disability evolution in these patients. However, the data on the disability outcomes in pediatric population with aquaporin-4 IgG antibodies are limited because we're studying mixed cohorts of seropositive and seronegative patients, or there are studies with short follow-up times, or there were cohort with heterogeneity across different countries and the healthcare systems. So we conducted this study, which aim was to investigate early predictors of long-term disability in pediatric onset aquaporin-4 NMOSD in a single country cohort. And then we compared pediatric onset early predictors with those from a UK adult onset cohort published on Brain Journal in 2012. We collected data about these pediatric onset aquaporin-4 IgG patients. The detection of the aquaporin-4 antibodies was performed using a cell-based assay in the neuroimmunology laboratory of Oxford. And we collected patients from 6 tertiary UK NMO centers, from the John Radcliffe Hospital, Great Ormond Street Hospital in London, the Walton Centre in Liverpool, Evelina London Children's Hospital, Birmingham Children's Hospital, and Royal London Hospital. We collected demographic and disease data, clinical information on the onset attack, so the onset phenotypes, optic neuritis, transverse myelitis, auditory syndromes, brainstem, cerebral syndromes, defined as ADEM, diencephalic syndrome, encephalopathies without typical MRI features of ADEM, and we assess whether this patient had multifocal syndromes. We assess whether the onset attack was severe or not. In particularly, we focus on transverse myelitis, optic neuritis, and brainstem syndromes. We collected data on disease course, particularly in time to first relapse, the first and the current long-term immunosuppressive therapy. And our main goal was to assess the long-term outcomes, defined as persisting for longer than 6 months. And we define visual disability as visual acuity in the best eyes worse than 6 out of 36 in the Snellen chart. Cognitive impairment assessed through neuropsychological assessments or documented learning disability requiring extra support at school, and ADSS-4. And these definitions were according to the definition used in the adult cohort paper. No, it's not going. Okay. Then finally, we did the statistical analysis with a descriptive and group comparison analysis and survival analysis on clinical long-term outcomes. We collected 49 aquaporin-4 IgG pediatric onset patients with a median disease duration of 79 months, female to male ratio 7:1, and a median current age of 21 years. About the 40% of patients were white, about 35% were Black, and 20.4% were Asian, and 6% were mixed. At the clinical onset presentation, appeared that white children had were more likely to have an onset at the age less than 12 years old, while Black children were more likely to have an onset between 12 and 18 years old. The three commonest onset symptoms were area posterior membrane syndrome, optic neuritis. About half of the patient had bilateral optic neuritis, 45% of patient unilateral optic neuritis, and transverse myelitis. 26.5% had a multifocal presentation. Severe onset attack occurred in 75.5% of the patients, so very high proportion of this patient, and the most severe location were in the spinal cord, so transverse myelitis and severe optic neuritis, but only 16.7% of the patient with the transverse myelitis and at onset were left with ADSS-6 after the onset event, and only 26% of these patients with optic neuritis at onset were left with visual disability after the onset event. 84% of these children had a relapsing course, 52% relapsed within 1 year from the onset, 67% within 2 years. Children aged between 12 and 18 years had a lower risk to have a first relapse compared to those aged less than 12 years at onset. As you can see in the Kaplan-Meier curve, children aged less than 12 years old at onset have a median time to first relapse of 5 months, while those aged between 12 and 18 years had a median time to first relapse of 17 months. And also the time to first relapse was related to the introduction of immunosuppressive therapy. Children who started the immunosuppressing therapy after the onset attack had their first relapse after 26 months, while children who at the first relapse weren't treated with immunosuppressive therapy had a first relapse after 5 months as median. Only 65% of patients were treated with IV metoprolol at the onset attack, and about 20% of this patient needed a second-line acute therapy with the plasma exchange or IV immunoglobulins. Black race and multifocal onset were usually more likely to need a second-line acute therapy. No acute therapy was given to the 30.6% of the patients, and 61% of the patients were treated as first immunosuppressive therapy with azathioprine, 14% with mycophenolate, 12% with rituximab. And as you can see in the table, discontinuation were more likely in azathioprine treated children and mycophenolate treated children. Only one patient treated with rituximab discontinued the treatment due to an intolerance because she developed neutropenia. The disability outcomes. So during the follow-up, 37% of the children developed visual disability, 18% developed ADSS-4, and 25% reached cognitive impairment during the follow-up. Which are the predictors of visual disability? We found that optic neuritis phenotype at onset was a predictor of visual disability with an hazard ratio of 7.8, and excluding the patient who developed visual disability due to the onset optic neuritis attack, the difference was still significant with an hazard ratio of 4.3. Moreover, we found that children with optic neuritis at onset treated with IV metoprolol plus a second-line acute therapy didn't reach visual disability, while about half of the children with optic neuritis treated with IV metoprednisolone only reached visual disability. The second predictor of visual disability was the white race, and especially comparing to Black children. White children had four times they developed 4 times earlier visual disability than Black children, as you can see here. For the ADSS4, we found that non-Asian race was a predictor of developing ADSS4, and this was a tendency overall because no of Asian children developed ADSS4 during the follow-up. And interestingly, children who had on transverse myelitis onset did not reach, were not more likely than those without transverse myelitis onset to reach ADSS4. Predictors of cognitive impairment, we found that cerebral syndromes presentations were more likely to develop during the follow-up the cognitive impairment than those who had different presentation. And also in this case, when we excluded patients who developed cognitive impairment after the onset attack, the relationship was still significant with an hazard ratio of 5.5. The second predictor was the resistance to IV metoprednisolone, and we found that patients who needed a second-line acute therapy were more likely to develop earlier cognitive impairment than those who didn't need a second-line acute therapy. And finally, we evaluated the multivariate hazard model, and we found that for visual disability, only we confirmed that white children and children with optic neuritis at onset were more likely to develop visual disability during the follow-up, while for cognitive impairment, the cerebral syndrome and second-line acute therapy predictors lost their significance, and probably it was because who had a cerebral syndrome at onset were more likely to need a second-line acute therapy and were resistant to IV metoprednisolone. And also in the multivariate hazard model, motor disability, we didn't find any predictors of motor disability in children, even transverse myelitis at onset. So in conclusion, summarize some key points. We found that younger children appear to have a more active disease and relapse earlier than adults and does need to be managed as actively as adults. Indeed, we found that time to first relapse in children aged less than 12 years was 5 months. Time to first relapse in children aged between 12 and 18 years was 17 months. And the time to first relapse in adult cohort was 14 months. However, this adult study noted longer delay to immunosuppression than in our older children, and therefore even the children aged between 12 and 18 years may have a more active disease than adults. The second key point was the second-line acute therapy, plasma exchange IVIG in those with a poor response to first-line IV metoprednisolone may reduce the visual disability in patients, of course, with optic neuritis. Several studies have demonstrated that plasma exchange is very safe and have a high efficacy in treating refractory optic neuritis, even in children. And we recommend the use of second-line acute therapy in any case of refractory IV metoprednisolone syndromes to reduce the risk of developing blindness in these pediatric patients. And the third key point was the early diagnosis, carefully monitoring, and relapse prevention treatment are important to reduce disability, especially in those with the risk factor for poor prognosis. And to summarize, these risk factors, as we saw, where optic neuritis at onset for visual disability, white rays for visual disability, a tendency of non-Asian children to have poorer motor outcomes, and for cognitive impairment, children who did not respond to second-line acute therapy, and those with cerebral onset, which had a greater risk of cognitive disability even in the future. And therefore, a cognitive testing should be routine to identify where practical intervention is required. So this is the final. Thank you for your attention, and thanks to all the co-authors of this paper.
Great. Thank you so much, Valentina, for that excellent presentation. I hope everyone enjoyed that. And now I would like to introduce our final speaker before we move on to our question and answer session. So I'm really so pleased to introduce you to Dr. Frederike C Oertel, who's currently based at the University of California, San Francisco. She received her MD, PhD from Charité in Berlin, and is now a postdoctoral scholar in San Francisco, supported by fellowship grants of the National Multiple Sclerosis Society and American Academy of Neurology. Frederike, we're so happy to have you with us this evening, and over to you.
Great, thank you. And thank you everyone for joining. Let me share my screen. Does everyone see this all right? Okay, perfect.
Yes, that's great, thanks.
Thank you so much for the invitation. And I would like to give you an update on recent research on retinal changes in NMOSD and MOGAD. As Valentina already said, afferent visual system involvement, particularly optic neuritis, is one of the key features of both aquaporin-4 antibody positive NMO and MOGAD, MOG antibody associated disease. And luckily, we have a great imaging technique called optical coherence tomography, or OCT, to quantify these afferent visual system changes. It's a non-invasive imaging technique, and we can quantify different retinal layers. Usually, we are particularly interested in the retinal nerve fiber layer thickness and the ganglion cell and inner plexiform layer, because these are the two neuroaxonal layers where we can see neurodegeneration and neuroaxonal damage after optic neuritis or independent of optic neuritis. In aquaporin-4 antibody positive NMO, we are additionally interested in astrocytic changes because astrocytes express aquaporin-4, an astrocytic water channel, and which is targeted by aquaporin-4 antibodies. And in the retina, aquaporin-4 is expressed in Müller cells, which are the astrocytic cells of the retina and spans through the whole retina, as well as other astrocytic cells, which are mostly located in the ganglion cell and inner plexiform layer, and in some outer retinal layers. We already know for some time that optic neuritis is very severe in NMOSD and MOGAD and causes extreme neuroaxonal damage, way more than, for example, in multiple sclerosis. And here you can see, as an example, two of our studies showing optic neuritis eyes in red compared to non-optic neuritis eyes in blue and healthy control eyes in gray. And you can see that in aquaporin-4 positive NMO on the left side, as well as in MOGAD on the right side, we see severe damage after optic neuritis compared to eyes without optic neuritis and healthy control eyes. However, we always wondered if in NMO and MOGAD, there can also be damage independent of optic neuritis, so progressive damage. And we started looking into that in aquaporin-4 positive NMO in 2017. And when we looked at the retina of these patients using OCT, we actually saw a shape change of the fovea in aquaporin-4 positive NMO patients without optic neuritis compared to healthy controls. And we saw a broadening of the fovea, the point of sharpest view, which is particularly interesting because astrocytes and astrocytic Müller cells have their highest density in the retina in the parafoveal area. So we thought maybe these parafoveal changes and these foveal shape changes are caused by astrocytic damage in aquaporin-4 positive NMO. And our group in Berlin developed this 3D shape algorithm to better quantify these changes in the fovea. And indeed, we found several parameters. Here I show the inner rim volume, which show that there is a foveal shape change in NMO, both in eyes with and without a history of optic neuritis, which we don't see in MS patients or in healthy controls. And these foveal shape parameters actually, and you see this in the lower right, can differentiate non-optic neuritis eyes of NMO patients very well from healthy controls. However, it seems like, or so far there's no evidence that these foveal shape changes are progressing over time. However, it was a first hint towards an astrocytic disease component in NMO, which causes optic neuritis or attack-independent damage. And we wondered if this can also cause optic neuritis-independent neurodegeneration. So we next investigated neuroaxonal loss in an NMO cohort without history of any optic neuritis compared to healthy controls. And we were indeed able to show with a median follow-up of 3 years that there is optic neuritis independent neurodegeneration in aquaporin-4 positive NMO compared to healthy controls, very likely caused by astrocytic changes. The big question is, do we also see this in MOG IgG positive patients, or is this specific to aquaporin-4 positive patients and astrocytic changes? So we just recently looked into changes in MOG positive patients, including 87 MOGAD patients measured at 2 different OCT devices, the Heidelberg device, and for confirmation, the Cirrus OCT device, from multiple centers worldwide. And already at baseline, you can see that eyes without a history of optic neuritis, here in blue, have no significant PNFL or GSEP loss compared to healthy controls. And longitudinally on the right side, you can see that eyes of MOGAD patients, here in red, have a slight decline in both PNFL and GSEP, but this is not significantly different from healthy controls. So it seems like that right now we have no evidence for optic neuritis independent neurodegeneration in the afferent visual system in MOGAD patients. This also means that probably the change we see in aquaporin-4 positive patients is indeed somehow aquaporin-4 IgG related and astrocytic. And we wondered if this actually has an influence on the functional outcome, because there was recently a study from Elias Satirchis and colleagues at Johns Hopkins showing that aquaporin-4 positive patients have worse visual outcome than MOGAD patients with comparable neuroaxonal content. So we looked into this in a monocenter cohort in Berlin, and indeed, we measured high contrast visual acuity in LogMAR. So the lower the visual acuity, the better, the higher, the worse. So 0 is great. And here you can see the relationship between neuroaxonal content and high contrast visual acuity for aquaporin-4 positive patients in black, MOG positive patients in yellow, and MS patients in blue. And you can indeed see that aquaporin-4 positive patients have worse high contrast visual acuity compared with MS patients and MOGAD patients with the same neuroaxonal content. And that's not only true for high contrast visual acuity, but also for low contrast visual acuity, which is not shown here, and for visual fields measured as mean deviation here in the lower row. But there's a cutoff value. So the relationship exists until around 60 micrometer of GCIP and also PNFL. And afterwards, we see a flooring effect. But now our question was, if maybe this worse visual acuity in aquaporin-4 positive patients is caused by some astrocytic change. So we use the inner rim volume which we previously have shown to be a parameter of astrocytic damage to the retina, and correlated it with both high contrast visual acuity and visual fields. And indeed, we see that in aquaporin 4 positive patients, and to a smaller amount in MS patients, but not in MOG positive patients, there is a correlation between visual acuity and inner rim volume, suggesting that there is an astrocytic contribution to this worse visual outcome in our patients with aquaporin 4 antibodies. But it's obviously not an astrocytic damage caused via PNFL and GCIPL loss. So our question was, where is this damage actually located? Why do these patients actually have worse function than, for example, MOG patients? And the most likely answer is obviously that we have a damage to the outer retinal layers. So we use the large international Croctino cohort to investigate outer retinal layer changes in our patients with aquaporin 4 antibodies and MOG antibodies as control, because we don't assume that they have any astrocytic changes. And we included nearly 200 aquaporin 4 positive patients and measured the 3 outer retinal layers, the outer plexiform layer, outer nuclear layer, and the photoreceptor layer. And interestingly, we didn't see any thinning of these layers in aquaporin 4 patients or MOG patients compared to healthy controls. So it seems like that these outer layers do not thin compared to healthy controls, despite the severe retinal damage we see in these patients. However, there are studies, for example, from Sasha Klastorner from Sydney, showing that he used ERG to show that there is functional damage in the outer layers, although we don't see a structural thinning of these layers. So we cannot make a final conclusion yet about outer retinal layer changes in both aquaporin 4 positive NMO and MOGAD, and we need more research on that. However, so far we can conclude that there's severe neuroaxonal loss after optic neuritis in aquaporin 4 positive NMO and MOGAD, and that we see probably astrocytic, but for sure optic neuritis independent retinal damage in aquaporin 4 positive NMO, and especially in the parafoveal area. But so far we have no evidence for structural outer retinal layer changes, and we also have no evidence for optic neuritis independent neurodegeneration in MOGAD. The functional loss after optic neuritis is severe in both aquaporin 4 positive NMOSD and MOGAD, but aquaporin 4 positive patients have a worse visual outcome when you compare patients with similar neuroaxonal loss, and this is very likely also caused by an astrocytic disease component. I would like to thank all contributors to these studies, my colleagues in San Francisco and Berlin, and all study participants, as well as you for your attention. Thank you.
Great. Thank you so much, Frederike, for that impressive presentation. I'd now like to open the floor to questions. Please feel free to use the chat or put your hand up and ask some questions. I'm sure there must be some interesting questions that have come out of all the wonderful work that we've seen here during this session. Okay, I'll kick off with the first question for Valentina. I wonder, Valentina, if you thought that the shorter time to first relapse in the pediatric presentation that you showed in people aged under 12 was related to the timing that their immunosuppressive therapy was initiated.
Hi, and well, we tried to adjust for the time to immunosuppression, and it was not corrected, so it was still significant. And then in the group comparison analysis, we found that the time to immunosuppression of patients aged less than 12 and patient between 12 and 18 had a similar median time to immunosuppression. So it seems that there is like a gradient in which younger children are more likely and they have a more active inflammatory disease than the older children that are during the adolescence are similar to adult, I would say.
Great, thank you. I see we have a question in the chat that has just come and said, oh, what about the type of immunosuppression? Did you see any? I'm assuming that's linked to the similar sort of chain of questioning, whether or not the type of immunosuppression played a role.
Sorry. We didn't adjust for the type because we had very few patients, for example, who had rituximab, which were only 6. And there are a few patients who had a methotrexate, for example, cyclophosphamide, one patient who had also MS drug. So it was difficult to adjust because the cohort is very small, and to maintain the power of the statistical analysis, we try to divide in less group as possible. That's if it was, it is a very good suggestion if we had a larger cohort, but it is very rare, so it was difficult to find even 49 patients.
No, of course. Of course. I think, did someone turn on their mic? There is another question in the chat, but I think someone was turning on their microphone to ask a question before that. Oh,
that was me. Thank you. You know, this is a little bit far afield, so I'm just going to tell you I'm part of the iWiMS that's really involved with rehabilitation. So I'm curious, for Dr. Camera, I saw that you indicate that early predictors of disability and cognition was kind of a primary one. Is there any evidence that cognitive, besides screening for cognitive changes, is there any effort to provide cognitive rehabilitation? And if so, is there any positive result from that?
For children at the moment, no, because also for collecting the data about cognitive assessment was quite difficult because they were not assessed like as a protocol as in adults, for example. And it was more complex because of the parents. And so it is more difficult to have a standardized assessment. And yeah, and it is like a retrospective study. So it will be very useful to develop some kind of cognitive rehabilitation, I think, for every kind of cognitive impairment demyelinating disease, even though in children, is more important. And yes, at the moment, we didn't develop this.
Yeah, I wasn't sure. I just was kind of curious because you found this, if that's a direction that, I mean, I feel like it's a direction someone should go, but I don't know how to make those connections, right? Thank you.
Yes, I think that personally, I think because I found that patients who had a cerebral syndrome at onset are more likely also to have other ADEM, other cerebral syndromes in the future. So they are more likely for this reason to have a cognitive impairment. Therefore, probably treating them with the more effective drugs since the beginning and monitoring them very strictly could be a good way to prevent the development of cognitive impairment, I think. Thank you.
Thanks. So moving back to the chat, there's a question for Frederike. Could you please comment on the usage of OCT angiography?
Yeah, thank you. I think that OCT angiography is extremely exciting, and it will have a great use also in neuroinflammatory diseases. I think right now the great thing about traditional OCT imaging is that we have international quality criteria and analysis criteria, and we don't have this yet for OCT angiography, and we don't have any common parameters yet for all OCT devices and so forth to use. So I think there's still some research to do until we are at the point where we can make valuable conclusions about the changes we see in NMO and MS and MOGAD, but there are promising smaller studies with 20 or so participants, which show that there are, for example, also parafoveal changes in NMO measured by angiography.
Okay, so some more questions for you, Frederike, in the chat. We have one. There are studies that suggest NMOSD patients have interval RNFL thinning independent of ON attacks. Given that we don't consider NMOSD a progressive disease, why might this be?
Yeah, so I love this question. That's great, because I think we are still debating if there is attack independent change in NMO. And I think there are studies showing one or the other. I think the studies we've done in the retina so far are all suggesting that there is an astrocytic disease component which is causing also progressive neurodegeneration in the retina over time. But I think we don't know yet if this is a global process or if this, for example, a local process, so if it is a retinopathy. We know that there are also studies, for example, from Ventura et al., showing the same process in the spinal cord, but I don't know if we can conclude that there's global neurodegeneration like in MS, or if it's, as Dr. Burden says, maybe more some regional or interval thinning, and not a continuous progressive process like in MS. I think we need more longitudinal studies to investigate that.
Absolutely. And then another question for you. Is there any association between the level of MOG titers and the thickness of RNFL in OCT?
Also a great question. There's not, but there are some studies about the association of aquaporin 4 titers and retinal changes, which are quite interesting. But I think most of these studies are limited by the fact that the aquaporin 4 titers were measured not in the same assay or at different time points. But for example, there's one interesting study which just came out from colleagues of mine in Berlin, suggesting that there's an association of aquaporin 4 titer, or also GFAP and NFL and retinal changes, which is quite interesting.
Really interesting. Some great avenues for future research. Do we have any other questions before we wrap up in the last minute of our session? Well, then in that case, I'd say we're right on time. I'd like to thank you all for attending today, tonight. It's been such a wonderful session. On behalf of Professor Pallas and Professor Asghari, I'd like to thank our speakers. They were really wonderful presentations with such exciting research. And then, of course, to Fabian, our incredible coordinator who makes these sessions possible. Thank you so much for all your effort and coordination of these events. Greatly, greatly appreciated. Thank you all and have a wonderful evening, day, wherever you might be.